Good afternoon, everyone. We are coming to you live from the University of the Philippines, Manila, for the 19th Lourdes Manahan Lectures in Rheumatology. I am Dr. Eric Amante, a clinical associate professor at UP College of Medicine, and I will be moderating this session. To begin with, I would like to thank our sponsor, Boehringer Ingelheim, for participating in this webinar. And to all our participants, thank you for joining us today. If you have any questions, you can place them at the Q&A box and we will address them during the open forum after the lecture. You will receive your certificate of participation to this webinar a week after you submit the evaluation form and post-test. The link will be posted at the Q&A box and at the chat box midway through the webinar. This is the third of our 8-part LMLR series for this year. The LMLR lecture series hopes to continue the advocacy in teaching rheumatology to our colleagues, initiated by the first Filipino rheumatologist flashed on your screen, Dr. Lourdes Manahan. The LMLR is in support of the Sustainable Development Goal 3, Health and Well-being, and SDG 4, Quality Education of the WHO. The Division of Rheumatology is also happy to announce its publication of the Atlas of Rheumatic Diseases in the Philippines under the leadership of Editor-in-Chief Dr. Esther Penserga this year. We hope that this book will be another medium of instruction on rheumatology for our students, fellow physicians, and other healthcare professionals and physicians with interest in the care of patients with rheumatic diseases. For those who wish to avail of the book, please email us at pgh.rheumatology@gmail.com. And now the third lecture of this year's LMLR, again, will focus on autoimmune interstitial lung disease. We are deeply honored to have two colleagues, friends, and very distinguished speakers this afternoon. Our first speaker is Dr. Albert Albay. Dr. Albay completed his pulmonary fellowship at the PGH and pursued post-fellowship training in pulmonary and critical care at the Tokyo Medical University Koshigaya Hospital in Japan. Currently, he is a clinical associate professor at the UP College of Medicine and is the recent head of the Central and Pediatric Intensive Care Unit in the Philippine General Hospital. He also leads the intensive care unit in Manila Doctors Hospital. Dr. Albay is well recognized in his field, having published numerous research and participated in clinical trials. He is also a prolific teacher and has served as the previous training officer for the Department of Medicine and the Section of Pulmonary Medicine at PGH. Our second esteemed speaker is Professor Michael T. He is a professor of physiology and rheumatology at the College of Medicine, UP Manila, where he also serves as the Vice Chancellor for Planning and Development. Vice Chancellor T is the current convener of the Asia Pacific League Against Rheumatology Special Interest Group in Genetics and is the chair of the PRA, Philippine Rheumatology Association Special Interest Group in Genetics. Dr. T has just finished his genomic research in systemic lupus erythematosus, a nationwide project funded by the Department of Science and Technology. Ladies and gentlemen, without further ado, let us welcome Dr. Albay and Dr. T as they share their expertise in today's lecture.
Good afternoon, everyone, and we'd like to thank the Division of Rheumatology for this invitation to be with all of you during this Lourdes Manahan lectures in rheumatology. So thank you very much for the invitation. And my task over the next few minutes is to discuss the approach to diagnosis of interstitial lung diseases. These are my disclosures. I do have engagements with Roche and Boehringer when it comes to continuing education for interstitial lung diseases. I was only given one objective, that is to discuss the diagnostic approach to your interstitial lung diseases and delineating the role of the generalist and the specialist. For us to be on the same page, let us first define what is interstitial lung disease. So interstitial lung diseases belong to the diffuse parenchymal lung disorders. They are a heterogeneous group of non-neoplastic disorders resulting from the damage to the lung parenchyma by varying patterns of inflammation and fibrosis. They share some clinical, radiologic, physiologic, or pathologic similarities, and hence they are able to group them into several disease entities. Interstitial reflects the fact that the pathologic abnormality begins in the interstitium. However, most of these disorders are associated with extensive alteration of the alveolar and the airway architecture because a lot of these interstitial lung disease patients come into us quite late already in their clinical manifestation. So this is coming from a 2013 document telling to us how the organizational or the umbrella of diffuse parenchymal diseases looks like. So under diffuse parenchymal lung disease, we have those of known etiology, for example, those that are drug-induced and those coming from rheumatologic diseases. Then you have those of the granulomatous type, for example, your sarcoidosis, and there are other forms that may have some other etiologies like genetic predisposition, like your LAM and your PLCH. No? Then there are your idiopathic interstitial pneumonias. More often they are non-familial, and under these idiopathic interstitial pneumonias, we categorize them whether they are the chronic fibrosing ILDs or IIPs like idiopathic pulmonary fibrosis and your idiopathic NSIP, and versus the acute or subacute fibrosing like your cryptogenic organizing pneumonia or what we have been calling before as BOOP, no? And your acute interstitial pneumonias. And there are two other entities which are smoking related, like your RBILD and your DIP. These have impacts on management. That is the reason why they are now categorized into these three subcategories. The management for IPF is different from the management of smoking related and that from the acute or subacute fibrosing type of ILD. Okay. So most patients with ILD come to the clinic because of symptoms of progressive dyspnea or a persistent non-productive cough. Okay? They may also come to the clinic presenting with pulmonary complaints, having other systemic diseases. For example, they already have an existing connective tissue disease, and now they come with this progressive dyspnea or non-productive cough. Now, some may be having symptoms because they were having exposures to their occupations. For example, those with exposures to asbestos or silica, and some will just come to you. They might not have symptoms, but they may be presenting with an abnormal chest imaging that warrants your investigation. Now, there are also some patients who would come to you because they were ordered for a lung function test, and then when they did their lung function test, there seems to be some problems already. Okay. So as internists and generalists, our first step is really to identify these patients with potential ILDs. If you look into the clinical presentation, they can actually fall into all the other types of pulmonary conditions. It is therefore important that a detailed history and physical examination be performed by us seeing these patients. This will guide us into the diagnostics that we will look into or perform to identify the potential etiologies. It is also important for us that once we have this working impression or a diagnosis for this patient, is to refer them to the specialist for further diagnostic and also for management. Okay. So let's try to take a look at what are the key points for our history. For example, patients with sarcoidosis, connective tissue diseases, and your LAM and your PLCH usually present at the early part of their years, at 20 to 40 years old. Patients with IPF will often present with a progression of their condition that starts maybe around their 40, 45 years old. And by the time they usually consult, they're usually above 50 years of age. A lot of them would think that maybe this is age related, and somewhere along the way, when the fibrosis is now more progressive and accelerated, these patients will seek consult to us. Okay. The gender is also quite important to consider. Your LAM and the pulmonary involvement of tuberous sclerosis are common in your women, in your premenopausal women, and occupational exposures may also be related to gender. So a lot of men are the ones engaged with work that is exposed to silica, like mining, or those with asbestos exposures. Okay. The duration of symptoms will be very important for us to narrow down our differentials. So if you have patients presenting with symptoms from days to weeks, you would probably think of your acute interstitial pneumonias, your eosinophilic pneumonias, or hypersensitivity pneumonitis, or even your BOOP or your cryptogenic organizing pneumonia. If you have patients presenting with subacute symptoms, meaning weeks to months, you will consider your drug-induced ILDs, maybe consider also your CTDs. Now, for patients who present with chronic symptoms, the thing to remember is look for the possibility that this is really IPF because this is more debilitating and it has an increased mortality. So it's very important for us to really rule in or rule out the possibility of idiopathic pulmonary fibrosis. There are other ILDs that can present with chronic symptoms like your chronic hypersensitivity pneumonitis, although these are usually progressive and there would be certain points in the year wherein they would experience such degree of condition, sarcoidosis, and your pulmonary Langerhans cell histiocytosis or your PLCH. Okay. The past medical history is very important for us to really look into. Try to check whether this patient had been diagnosed with CTDs or if there are already manifestations of CTDs in this patient that may increase the likelihood that the interstitial lung disease is brought about by a rheumatologic condition. Look for signs of inflammatory bowel disease because there are conditions that this is tied up with the development of this interstitial lung disease. Look for previous malignancies because sometimes the malignancy may be the one causing the ILD or it might be because of the medications that they have received that is causing the interstitial lung disease. For patients with hypersensitivity pneumonitis or eosinophilic pneumonias, look into the history of atopy like asthma, allergic rhinitis, because this might guide you to diagnosing eosinophilic pneumonia, so even your Churg-Strauss disease. The smoking history, again, is very important because there are conditions that are quite common or linked to the smoking history of your patient. So, for example, your DIP and RBILD are closely linked with smoking. They largely occur among current or former smokers versus your hypersensitivity pneumonitis and your sarcoidosis, which are often seen in your non-smoking patients. Okay. Again, there's about 20% familial history of interstitial lung disease, so it's important for you to look into that as well. So in the Philippines, when I came back from training, I got at least two patients coming from one family with one patient already died of idiopathic pulmonary fibrosis, and one patient had been diagnosed with it, and another sibling is now being monitored for the possibility of IPF. Now, look into medications. There are some medications that can increase the likelihood for your patient to develop ILDs. For example, cardiac medications, your amiodarone is there. Radiation therapy that involve the irradiation of the chest. Example, your breast cancer patients, they do have some irradiation and sometimes it can penetrate into the lung parenchyma, although newer modalities of radiotherapy are limiting that particular exposure. Cancer medications. So right now you have a lot of immunotherapy being given to our patients. So there's now a thing that we call as checkpoint inhibitor pneumonitis, wherein they present with interstitial lung disease of the acute setting, and it mimics your pneumonia, it mimics other conditions, and when you look into the diagnosis, it's just because of an inflammatory ILD brought about by these cancer medications. Look into exposures, dust, gases, chemicals, exposures to livestock, animals, and birds. There are changes on the X-ray or even on the CT scan that may mimic interstitial lung disease. So we do have cases wherein the picture seems to be really a honeycomb appearance on the and the CT scan, but these patients are quite of the younger age. They're not the usual IPFs of more than 50 years old. And when we do our histologic diagnosis in this patient, and they turn out to be histoplasmosis, which is an infection brought about by exposure to these animals, and birds. Okay. So on physical examination, the lung findings for ILD are usually non-specific, but most forms of ILD will create the Velcro routes that we usually hear, no, or usually describe. The cardiac examination can also be normal, except in advanced cases of pulmonary fibrosis when pulmonary hypertension or cor pulmonale has already set in. Clubbing, when present in your patient, is often a late manifestation. There's already a chronic hypoxemic state in your patient. And in the PE, look for extrapulmonary findings of systemic disease. So again, try to take a look whether this patient has signs of autoimmune diseases. And you will usually find this in a thorough physical examination of all the other organs of your patient. So how do we approach patients with interstitial lung disease? So it begins with a suspicion. So again, the clinical presentation of your patient plus your thorough PE and history will be a link for you to suspect ILD. So you do an initial PE and history. You may want to really do, because you really need to rule out your autoimmune disorders, a CTD serology and a chest high resolution CT and a pulmonary function test, because we really need to determine what's happening in the lung parenchyma and if there is extensive damage already in the parenchyma and if the airway is being involved. If a potential cause or associated condition has been found based on your initial investigation, then this patient is likely not IPF. Again, the move towards approaching ILD is to check whether this patient has IPF, because these are progressive, the mortality is high, and the lifespan of your patient is short. That's why you really need to identify ILD for you to reduce or to slow down the progression of your condition. Now, if your chest HR, if this there's a potential cause that has been found, then you look into your chest high resolution CT. And based on the high resolution CT, the diagnosis can be derived whether your patient has a probable IPF. So IPF, on histology and on radiology, would be called your UIP, or your usual interstitial pneumonia. So your usual interstitial pneumonia will have lesions which are usually subpleural and basal predominant, although the distribution is quite heterogeneous. So it involves all parts of the lungs, but there is a predilection to the bases and the subpleura. Honeycombing is present, and there may have peripheral traction, bronchiectasis, or bronchiectasis. So the honeycombing is quite important, because when this is present, this is high likelihood that this patient has IPF together with all the other symptomatologies of your patient. Now, there are two other categories on the HRCT scan. So your probable UIP, wherein they do not fit the classic UIP pattern, and the indeterminate UIP, wherein they do not have really the manifestations or the radiologic findings for UIP. And from here, you determine what is the likelihood for your patient to have UIP based on your HRCT pattern. Okay, if your HRCT pattern is consistent with the UIP, then you proceed with a multidisciplinary discussion. If you have probable UIP or indeterminate, or an alternative diagnosis is offered by your HRCT, you still proceed with an MDD or a multidisciplinary discussion. The multidisciplinary discussion is a dynamic integrated approach that was introduced in the 2013 Consensus for Interstitial Lung Diseases. This has replaced the gold standard, which has been a surgical lung biopsy, and we now have the MDD as the gold standard for diagnosis. This will require a close communication between the ILD clinician, the radiologist, and when appropriate, the pathologist, if you did or plan to do a surgical lung biopsies. Other specialties may be included. depending on the need and the diagnosis that you're actually thinking for your patient. Here, during the MDD, the clinical data, which includes the history, the exposures, the associated disease, the laboratory findings, the lung function, and the radiologic functions or findings are discussed and quite essential for you to arrive at a consensus diagnosis through an MDD. The MDD was able to help us define which patients would really need to have a biopsy and which patients can proceed with with a treatment or with a management immediately. Okay, so if your patient is now categorized based on the MDD as UIP, then you proceed with the management for interstitial pulmonary fibrosis. Now, if your MDD tells you that it is indeterminate or probable, then you proceed with other diagnostic tests, which includes a BAL and probably a surgical lung biopsy. And hopefully, the surgical lung biopsy and the BAL will provide you with a diagnosis whether this patient has IPF or other conditions that can cause interstitial lung diseases. When we do a surgical lung biopsy, these are the histologic patterns and the features. Again, similar to your radiologic patterns, they are categorized as UIP, probable UIP, or indeterminate or alternative diagnosis. So the typical UIP or IPF patterns on histology will be a dense fibrosis with a lot of architectural distortion, which means that you may have some scarring and honeycombing. Again, the distribution would be subpleural. There will be patchy involvement of lung fibrosis, and when they look into the cellular component, there will be a fibroblastic foci in this UIP histologic patterns. And there would be an absence of other features that would suggest an alternate diagnosis. Okay, and here we listed also the histologic patterns for a probable UIP and indeterminate UIP. So how does the radiologic and the histologic pattern fit into the diagnosis? So this is how we do it. So if your histology and your HRCT is consistent with UIP, then that patient is likely IPF. No. The bothersome would be if you are on the alternate diagnosis or in the indeterminate category. So if you're indeterminate for UIP, but the histology is probable UIP, then the likelihood of IPF is there. So that patient would be treated as if it is IPF. Okay, and for the rest, those with the non-IPF diagnosis will be treated in a different manner. Okay. This is important for us to determine what type of ILD your patient will have because of the difference in the treatment goal and the monitoring strategy that you have. So remember, you have your smoking-related ILDs, for example, your RB-ILD. These are usually reversible and self-limiting. And the way to go about it is to remove the inciting agent, which is often the smoking. And removing the possible cause may actually slow down or remove the progression of your condition. And in these particular patients, we usually follow them up short term. So I have a patient with RB-ILD that I have been following up for the past 3 years. And so far, this patient had stopped smoking and there is no more progression. And there is indeed some regression of the RB-ILD lesions on the HRCT. Now, there are other conditions like the ones with the subacute fibrosing, wherein the disease can be reversible, but there is a risk for progression. So these would include your cellular NSIP, your cryptogenic organizing pneumonia. So the treatment goal is really to stop the acute condition. So try to reach your initial response and then look whether there is a need for you to have long-term therapy. Most of the time, these patients will just be observed and look into relapse. And whenever they would have relapse, you would need to treat them again. Now, under the chronic fibrosing interstitial lung diseases, you would see three different patterns. Those with stable residual disease, wherein these patients will just be monitored on a long-term basis and assess if there is progression, then you treat. There may be patients with progressive irreversible disease, and the goal here is to really stabilize this patient and observe them on long term for disease progression. Now, there would be those with progressing diseases despite you instituting therapy. And the goal of management is really to slow down the progression. Here, these patients should be monitored long term and they are already candidates for transplantation. And if you don't have transplant, then you consider palliative care for these groups of patients. Now, it has been difficult to really evaluate interstitial lung diseases in the setting of COVID-19, but the ATS and the European Respiratory Society did show us or tell us or gave us some guidance on evaluating patients with ILDs during this pandemic. So this is how it's now being done in the setting of COVID-19. So we do our initial consultations, the first steps here via teleconsult. You can complete the 1, 2, and 3 in most patients, and we usually defer the pulmonary function test if the cases of COVID-19 are quite high because this is an aerosol generating procedure. Okay? The goal of the management during this time of pandemic is to really minimize the delays in diagnosis and minimize the time from managing this patient while avoiding the non-essential contact with your healthcare system. Okay? We consider performing the tests like for example, your pulmonary function test or even your HRCT during the off-peak hours or in the hospital facility or the clinic is not congested and there would be considerable short waiting times inside the unit. And if you are able to do some mobile related laboratories that can be done remotely. Again, perform tests only if these are needed to provide further information because the management would become quite different. Okay, so the MDD is still there. It can be done virtually with at least the clinician and the radiologist. And the diagnosis made with lower diagnostic certainty may be required given limited access to tests and procedures. And you include a lung pathologist in the MDD discussion because you would need to determine the urgency of doing these invasive procedures. Okay. The MDD, hopefully, we still don't know if the MDD will have an impact on short-term management. So therefore, you determine whether the results of your discussion or the diagnosis that you have arrived at is certain or not. If your diagnosis based on your HRCT and the discussion with your interstitial lung disease clinician is already more than 90% certain that this is IPF, you defer further testing and you push towards managing already your patient as IPF. If your range is between 50 to 89%, then you balance off pursuing additional tests versus observation versus empiric treatment. No? You might want to start some treatment, especially if the patient is very symptomatic and there seems to be some progression, and proceed with some tests later after the pandemic. For those whose certainty is less than 50%, balance off whether you're just going to observe for now and proceed with tests if urgently needed because your short-term therapeutic decisions would have an implications for this. Okay, we usually defer BAL and the surgical lung biopsy during surges and times of COVID-19. And if ever you will be performing certain this test, try to really reduce the risk of aerosolization and the potential for your healthcare team to be infected. Okay. For patients who have not undergone some of the tests or you decided to do a therapeutic trial, it is important to reassess this patient once the numbers of your cases are going down and determine the risk-benefit ratio of proceeding with further tests to reach diagnostic certainty in these groups of patients. So in summary, we've discussed that ILDs are really a heterogeneous group of disorders having a pathology that starts in the interstitium, leads to parenchymal damage marked by varying patterns of inflammation and fibrosis. As internists, a thorough history and PE will guide our diagnostic approach. The specialists are the ones usually in the MDD already or the multidisciplinary discussion, looking into the symptomatology, the history, and the laboratory diagnostics. that you have to determine whether this patient has IPF or not. Remember that the multidisciplinary discussion is now the gold standard for diagnosing ILDs, replacing the surgical lung biopsy. It involves a collaboration and discussion between the clinician, the radiologist, pathologist, and other specialists as the need arises. And the patterns of presentation, together with HRCT findings, can identify patients with UIP, reducing the need for your surgical lung biopsy. And that despite the pandemic, the MDD can still be performed. But remember that there are now balancing acts that are done with regards to the risks of the procedures being performed versus the potential benefits and the relation of that with the management of your patient. So thank you very much for listening.
Good afternoon and welcome to the Lourdes Manahan Lectures in Rheumatology. I'd like to thank Albert for paving the way so that the diagnosis is now easier for us to understand. I'd like also to thank our division chair, division chief, Dr. Salido, for this opportunity to lecture on connective tissue disease related ILD or CTD-ILD with special focus on pathology and management. These are my disclosures. And before I start, I'd like to welcome Dr. Jeff Sui. I see her in the audience. She's a prominent alumna of the department and of the college. Albert already walked us through the diagnosis of these CTDs. And CTD-ILD just belong to this broad group of ILDs. And I would like to focus on this blue labeled list of CTD-ILD. There is interstitial pneumonia with autoimmune features, meaning you have ILD and some autoimmune features that cannot fulfill any one of those listed on the right. As you would know, many of our rheumatology diseases have criteria, whether diagnostic criteria or classification criteria. And when it's written to have with autoimmune features, it means we have not decided whether it falls under any one of the categories on the right. It's important to note that ILD may be the first clinical manifestation of a CTD, and that the interstitial pneumonia with autoimmune feature is a research term used to describe patients with idiopathic interstitial pneumonia who also may have features suggestive of a CTD. Almost 20% of ILDs reported in Europe and the US are associated with connective tissue disease. And among our patients, many will succumb to CTD because of complications from ILD. And factors associated with its development are usually similar for all. No? Genetics, we talk about genetics, risk factors, the environmental situation where it happens. And right now, when we talk about the environment, many rheumatologists are interested not just in the external environment, but also the internal environment. In fact, we are currently being evaluated for gut microbiome studies, and this exemplifies one of the internal environmental factors that may trigger or result to development of connective tissue disease. There are immunologic factors, the presence of what antibody affecting which organ should be evaluated. And when we talk about genetic susceptibility, various CTD-related ILD will have its own pathogenic mutation. For instance, rare pathogenic mutations in the telomere maintenance gene and chromosome-protected terminal telomeres may result to pulmonary fibrosis. Patients with rare TERT or TERT will exhibit various forms of pulmonary fibrosis ranging from idiopathic pulmonary fibrosis, interstitial pneumonia with autoimmune features, to various kinds of CTD-ILD. And a gain of function of the MUC5B promoter variant with SNP RS3570550 accounts for 30% to 35% of developing the disease. In fact, it's been known that genetically driven MUC5B overexpression in the MUC5B protein can hinder celiac clearance, and this will disrupt the normal lung repair mechanism. And if you cannot repair, you'll have bad scars. In the environment, we talk about GERD. The prevalence of GERD in ILD can be as high as 94%. Animal studies have shown that chronic aspiration lead to pulmonary fibrosis. In the clinics, we see patients with GERD complaining of chronic cough, especially when they lie down in bed. So this repetitive chronic microaspiration result to lung injury and may result to pneumonitis, increasing epithelial permeability, fibrotic hyperplasia, and ultimately, again, pulmonary fibrosis. We talk about infection, pneumonia, but more than that, in the GERD, some patients with GERD may also have Helicobacter pylori in their gastric juice, and this adds to the injury. Now we have both chemical as well as infectious related injury, thereby promoting progressive pulmonary fibrosis. Environmental, chemical, and tobacco smoke was discussed by Albert. Now, toxic substances like drugs are also blamed. When I was training, methotrexate is among those drugs that have been blamed for the development of ILD. However, recent studies are saying, no, perhaps not. Perhaps it's just there, but it's not a participant or a causative agent for the development of fibrosis. Immunologic factors, we talk about innate and adaptive immunity with B-cell infiltration in systemic sclerosis ILD. T cells may release fibrogenic mediators and stimulate fibrotic response. Toll-like receptors, depending on the number, like pro-fibrotic TLR2 and TLR9, anti-fibrotic TLR3, pro and anti-fibrotic TLR4, will be overexpressed. And these are usually discovered when they do a bronchoalveolar lavage, and the fluid is tested. You count how many T lymphocytes and peripheral blood monocytes are there, and then other molecular biology techniques will allow you to now evaluate this. Clinical characteristics. It's difficult to say whether these constitutional symptoms are due to ILD or CTD or even infection. So really, when you need to see a patient, you have to see them. It will be most effective if you see them face to face. I'm saying this because of what Albert was also mentioning earlier about the effect of pandemic on the way we see patients. But if you need to really evaluate a patient, the best will be to listen to the lungs. Respiratory dyspnea, exercise intolerance, dry and non-productive cough with slow progression over time are specific or are non-specific rather, but seen in relation to CTD and the absence of infection may really bring you to a conclusion that this is a CTD-ILD and trigger what the cascade of of diagnostic examinations previously enumerated. Chest pain, palpitation, tachypnea, and hemoptysis are late symptoms. And when that happens, you will be very sad because perhaps you missed the diagnosis or the patient came late, that it's already very difficult to treat the patient. Demographic factors are important when you need to look at clues. If you have a patient with systemic sclerosis, they are usually older, male, and it will come early in the disease. No? Not among those who have had SSC for 20 years. No, it will come early, on the average 2 years. And then RAILD would be associated with active articular disease, meaning the patient is not responding well to your treatment, or what we call inadequate responders. They would have elevated rheumatoid factor titers and present anti-CCP antibody. Anti-CCP, especially among smokers with RA. For PM, DM, and ILD, they will have arthritis, arthralgia, and fever, and the presence of these antibodies. In fact, if I remember right, in 2020 or 2021, there was a case report reported by a fellow of the University of Santo Tomas and published in an Aplar journal, specifically looking at this patient who had PM, DM, ILD with positive anti-MDA5 antibody. It's been a long time, so forgive me for forgetting. Sjogren's syndrome is Raynaud's phenomenon, peripheral arthritis, and esophageal involvement. Look at these two, no? SSC and Sjogren's, they are both related to esophageal involvement. And these are patients who would really be more commonly presenting with ILD. But really, SSC will be most common, and the pattern will be non-specific interstitial pneumonitis, and this will develop first year, 5 years of the disease course. So mixed CTD will follow. PMDM, these are patients who would have difficulty swallowing too. RA, especially smoker RA. Sjogren's 10 to 30%, and SLE is a very low prevalence among SLE patients. Having seen this, one question will therefore be, if I have SLE, what kind of ILD will I be most prone to develop? Now here you'll note they are more prone to develop pleural disease. But SSC will have vascular disease. That's consistent. Telangiectasia, vasculitis, livedo reticularis, Raynaud's phenomenon, and pulmonary hypertension. And then you add there the ILD and NSIP. For RA, mainly are airway disease, ILD, NSIP, UIP, and OP, DAD. So that's diffuse alveolar hemorrhage or diffuse alveolar damage. Now, the common pathogenic pathways that lead to fibrosis can be traced to this one. There's activation of these fibroblasts. Profibrotic mediators will recruit and activate the fibroblasts. They will then differentiate to myofibroblasts and result to large or high quantity of extracellular matrix secretion. This will result to a feed forward, or what we call in physiology positive feedback mechanism, where it leads to a self-sustaining progressive lung fibrosis. I hope this illustration can best capture that. No? You have the susceptibility gene, you have poison or toxic agents, smoking, infection, and GERD, affecting a normal lung. Normal lung may be of a patient with CTD, and then there is an inflammatory pattern already as a result of infiltration from antibodies, neutrophils, and macrophages, the B cell, the toll-like receptor, and macrophages, resulting to fibrosis because the fibroblasts have been activated, and this secretes increased extracellular matrix, and therefore will have thickening of the alveolar area. So Over time, there will be endothelial cell dysfunction, granuloma formation, and alveolar macrophage activation, resulting to further inflammation. This may be just for you to screen capture because Dr. Albay has discussed all of this. So the treatment guideline are mostly centered on the management of SSC-ILD because it's most common. It's really difficult to conduct clinical trials among these patients. And among CTD-ILDs, these are the treatment options: steroid, azathioprine, cyclophosphamide, and mycophenolate. Biological immunomodulators will include rituximab, tocilizumab, and abatacept. As to the antifibrotic, there's only one approved, which is nintedanib. So here we attempt to show you where it will affect. In the activation of leukocytes, B cell, T cell, macrophages, and dendritic cell, you can see that azathioprine, mycophenolate, mofetil, cyclophosphamide, corticosteroids, and tocilizumab will be most effective, while nintedanib will have its effect on the vascular and endothelial growth factor, platelet-derived growth factor, TGF, transforming growth factor beta, TNF alpha, TNF beta, interleukin, and chemokines. So this is how we usually give it among patients with CTD-ILD. Corticosteroids is best given to patients with RA, collagen disorders including SLE, PM, and mixed CTD. Note that while I told you that SSC is common, it is not a disease that will benefit from giving corticosteroid. Maybe, maybe a little. But you have to be very careful because these patients will are at risk for scleroderma renal crisis when you give them high-dose corticosteroids. Also note that in giving these immunomodulatory therapies, you have to really rule out the possibility that there is tuberculosis, pneumonia, viral disease that may worsen when you give immunomodulatory therapies. And this is where the partnership between radiologists, pulmonologists, and rheumatologists will come into play. You have to distinguish whether that lesion in the lung is a simple CTD-ILD and not related to other pathology that in Tagalog will call bubulaga na lang sa'yo at mahihirapan ka ng gamutin pa pagkatapos niyan. So azathioprine is given for severe active RA, PM, DM, SLE. Adverse events would include thrombocytopenia, nausea, bone marrow function, and leukopenia. So you don't want patients with ILD CTD to have leukopenia. Cyclophosphamide is has the same relevant adverse events, but it's usually given at 2 milligram per kilogram with a titration of 25 milligram monthly. I must admit that in my practice, it has been difficult to start cyclophosphamide tablet. What we usually do is give it IV once a month. For mycophenolate mofetil, it is given at 500 milligrams twice a day to as high as 3 capsules or 3 tablets twice daily. The science of giving cyclophosphamide stems from this scleroderma lung study that was published in 2007. No? Starting cyclophosphamide requires a strict criteria. So we have to know what is the FVC of the patient. Again, this is where our friends from pulmonology will help us. I cannot interpret FVC1, FEV. So I will need them to tell me whether the patient fits the criteria of less than 80% predictive and not lower than 45% predicted. Otherwise, I will not be within the window of benefit. So here you'll note that patients given cyclophosphamide have better FVC, TDI, whether they have limited or diffuse scleroderma. So that is where we really need the assistance. So, but overall, we know that if the patient is a good candidate for cyclophosphamide therapy, give it and the patient will benefit. But again, cyclophosphamide is associated with more than its usual share of what is unacceptable adverse events, especially given at as a capsule or tablet, no, including hematuria and bone marrow suppression. So what was done is compare MMF versus cyclophosphamide. And it was noted that in giving cyclophosphamide and MMF, you have similar effectiveness after 24 months. In this study, cyclophosphamide was given for 12 months and then placebo for 12 months. And then oral MMF was given for 24 months. The idea was if you stop cyclophosphamide, the benefit will no longer be there after a few months of stopping. But here they noted that there was sustained effectiveness, but again, MMF proved to be safer than cyclophosphamide. Now, biologics, tocilizumab, rituximab, and abatacept. Maybe among these, the audience will be more comfortable talking about tocilizumab, it being a popular drug for the management of COVID-19, also COVID-19 of the lungs. No? So here it's given at 162 milligrams once per week. And based on this study published in Lancet Respiratory Medicine, while it did not meet the criteria for skin recovery or skin improvement, there was a sub-analysis that was done. No, it cannot be the secondary outcome, because when you fail on a primary outcome, your trial is no longer able to interpret its secondary outcome. So this is a secondary analysis. And a pre-specified exploratory analysis, they counted how many or what percent of the population will have a decline of more than minus 10%. And here, they noted that in those given tocilizumab, it's only 5.4%, and almost 17% for those with placebo. And then if you look at the effect of placebo and tocilizumab, you'll note the tocilizumab prevented worsening of systemic sclerosis, ILD. For antifibrotic therapy, I'll only discuss nintedanib, it being the only available and licensed drug for SSC, ILD, IPF, and chronic fibrosing ILD. It is given at 150 milligrams twice daily, 12 hours apart. Now, some adverse events would include diarrhea, increased hepatic enzyme levels, and bleeding. The science is published in New England Journal of Medicine, showing a difference of 41 cc per year with a p-value of 0.04 and a relative reduction of 44%. So this is that difference. And then the mean difference also, look at the nintedanib here. After 52 weeks, the mean alveolar change from baseline is higher for placebo than nintedanib patients. And because of these developments, an algorithm for the treatment was suggested that let's say you have ILD on high resolution CT scan, meaning the patient was already seen by Dr. Albay. I have a patient with RA or SSA. I refer to Dr. Albay. He requests for HRCT. HRCT was read by our expert on reading HRCT for ILD, and he said, oh, there's clinical ILD. So we look at the lung involvement. If it's just lung involvement and without skin, you can give nintedanib. Or you can give immunomodulatry therapies such as MMF and cyclophosphamide based on my previous discussion. If you have multi-organ involvement already, then give almost everything. And then there is progression, you add nintedanib. And in any of these subclinical and all, if you have progressive ILD, you add nintedanib, maybe add rituximab or hematopoietic stem cell therapy, lung transplant, and then check with your friends in the multidisciplinary group. Do you have clinical trials where the patient can join? Because really, if after escalating to this therapeutic opportunities or options, there's nothing still, then maybe it's time to look at the latest advancement. And there are several clinical trials right now that are recruiting patients. So thank you for listening, and I hope I was able to explain how connective tissue disease-related ILD is managed based on the pathology associated with it. Magandang hapon po sa inyong lahat at salamat.
Okay, thank you so much, Dr. Albay and Vice Chancellor T, for your insightful lectures. We really learned quite a bit, and it's a pleasure and privilege to moderate this session. We have some questions already for you in the Q&A box, so I'll go over them and maybe we can go over them one by one. The first question, so for Dr. Albay, if HRCT is not available, would a plain chest CT scan suffice, or is it better with contrast? From Anonymous. Marami tayong anonymous na questions.
Okay, so the reason why we wanted a HRCT is because the resolution is really finer, the cuts are thinner. So for ILD, unfortunately, the recommendation is really to do an HRCT. Because remember, we will need this in the decision for the multidisciplinary discussion. A plain CT will not be, might not be able to give you enough the details unless probably if you see the honeycombing already. So if this is an IPF and there's honeycombing, then probably just go for a plain chest. You don't need a contrast unless you are thinking of other conditions that are associated with your patient.
Thank you. I think I'll segue to Dr. T. So Mike, in your usual, for example, scleroderma patients, just so the audience would know, do you routinely do imaging or PFTs? And if so, how do you go about it to ensure early diagnosis?
Yeah, first we establish the possibility that the patient has systemic sclerosis, do an adequate physical examination, comprehensive. And then if I hear something, and then in the history, the patient complains of frequent coughing, dry cough, some irritation of the throat, then an X-ray will be done. You find something, you do HRCT. No. And then if I don't know the answer, I refer to pulmonologists to confirm. Because in the idea really in ILD is to catch early, so you prevent fibrosis. And then admit that I don't know many of what they know in terms of interpreting the CT scan, the imaging.
Okay, thank you. For Albert, how often is lung biopsy requested for interstitial disease? I guess he's asking about numbers and how in the Philippines, maybe perspective.
So prior to the establishment of the MDD, the gold standard is really to do a lung biopsy. And we are really pushed to do the surgical lung biopsy in a lot of our patients. But the reality is some of our patients will not be able to tolerate such procedures. If the patient is already at the progressive stage of this fibrosing ILDs like IPF, they will not be able to survive those biopsies. We did try to look into doing transbronchial lung biopsies, wherein we just do an endoscopic procedure. The yield, however, is not as good as that of a surgical lung biopsy. So prior to the MDT, they say that about 60 to 70% of patients may be able to go for a surgical lung biopsy. with the results of the MDD, it has been already looked into what are the effects of our MDD. So about 30 to 55% already had a change in diagnosis after going to an MDD. For example, if my initial pre-MDD diagnosis was IPF, after the multidisciplinary discussion, it turns out to be a different ILD. It turns out to be a occupational related or infection related ILD. So about 30 to 55% would have a change in diagnosis. And about 40% of patients after an MDD will automatically go to a treatment. So if you look into that number, a great number of patients will no longer warrant to proceed with a surgical lung biopsy and may be able to go to a direct management. And of course, the bottom line of treating or discovering ILD is to halt the progression.
Thank you, Dr. Albay. So the next question, or one of the questions is there an added benefit of antifibrotics on top of immunosuppression for the treatment of patients with CTD-ILD? And I think we will have Dr. T answer this. I know he mentioned this in the slide earlier. And I think we can also maybe expand that, Dr. T, to you showed an algorithm, and maybe you can tell us how many months would we consider a treatment failure before going to escalation therapy and adding antifibrotic therapy?
Yeah, we will usually have to evaluate for about 3 to 6 months. In rheumatology, that's a standard, almost a standard way of evaluating patients, looking at progression or improvement within 3 to 6 months period. Remember, among patients with CTD-ILD, you're not just treating a patient with ILD. We have to treat the underlying connective tissue disease. A patient with RA, for instance, developing lung disease, you will have to evaluate and treat them for the joints. No? Sometimes these patients are really inflamed that you'll have joint involvement, you have eye involvement, and then you have the lung involvement. Sometimes treating them with biologic agent is enough to quiet everything. Everything will behave, the joint count will decrease, and then the eye redness will resolve, better eyesight, lungs will improve. But if the lung does not improve, then that's the time you consider adding an antifibrotic agent. That is actually what the algorithm is saying. In patients with progressive type of ILD or uncontrollable type of interstitial lung disease, you might benefit from antifibrotic treatment. But starting this again, you see there is a difference. If you have a patient with RA, you see ILD, yes, ILD, and then you try the biologic agents. You give steroids, you give methotrexate, and then you start referring for pulmonary function tests, because pulmonary function tests will allow you to stratify the patient's chance of success. Maybe Albert can teach us how he does the evaluation on when to start treatment aside from imaging, because FVC, FEV, they are criteria in many clinical trials that trigger inclusion and exclusion.
Yeah, maybe we can get the view of Dr. Albay on that. I agree with Mike. I think clinically we have patients who you can start to see the decline in the pulmonary function test. So what do you in the pulmonary world or personally consider a nice cutoff for initiation of treatment with regards to the PFTs? For Dr.
We
Albay.
usually look at two values when we do our pulmonary function test. We look at the FVC, and we also look at the DLCO. It's a diffusing capacity of your lung for oxygen. No? So we usually look into what are the numbers. So if, for example, your FVC is still above 40 and your DLCO is still in the range of 30 to 90, then you may warrant just a little bit of observation for this patient. But if your numbers are, if the FVC is already reduced and the DLCO is going down, then these are patients that you would really need to be aggressive with. there are combinations that we look into. So an FVC of less than 70 and a DLC of less than 50 might be a trigger for you to consider close follow-up. And if on your close follow-up, there is a decline in your FVC by about 5 to 10%, then you will consider more aggressive treatment. So we do have numbers to consider at the initial, and we do have numbers to consider also with regards to monitoring. And the monitoring for pulmonary function tests in these groups of patients is about every 3 to 6 months. Okay? Might be needing earlier if your clinical picture tells you that there is progression talaga.
Okay, thank you for that. And again, it emphasizes as you can see during our discussion here, the need for interplay between the internist, the rheumatologist, the pulmonologist in this multidisciplinary approach to treat. No, there was a question about which part of the history and PE would you really consider ILD that will distinguish it from other lung diseases? I think Albert addressed this quite well earlier. It's quite a long discussion. No, are there any tips that you have for them, Albert, that some rare cases where you've sort of come up with ILD where other people have not, things that you picked up? Or is it really a matter of just more extensive history and PE on your part?
I think as pulmonologists, we are at the tail end of the diagnostics, at least here in this country. So more often what we get as referrals are patients who don't seem to be improving after multiple treatments for tuberculosis. And then when you review their history, there has never been an instance that this patient had a positive microbiologic test for TB. And when we look, more often than not, these patients will also have their imaging with them. And so medyo medaya on our part, no? Because when it comes to ILDs, the patterns on the CT scan are very important. You will be able to determine those 5 patterns already just by looking into the CT scan and tying it up with your history and PE. Now I do receive referrals wherein they think it's ILD, but when I look into it, talagang hindi siya ILD. It's not even CTD. This is just a post-TB bronchiectasis or cicatrization. So it's actually a conglomeration of all of this manifestation. But do watch out for a patient who doesn't seem to be improving despite multiple treatments for tuberculosis and presenting with fibrosis on the X-ray that is quite extensive. I think it's a more common pattern that I see in this country.
Yeah, Dr. Amante.
Yes.
Can you allow me to ask a question?
Go ahead.
Yeah, all of these recommendations happened before COVID. Many of the information here relate to COVID, to non-COVID infection. Now that we have patients who had COVID, how will that affect our diagnosis and management of these patients?
It's important that we will know their pre-COVID status. Okay. Their pre-COVID condition will determine whether we are looking into a post-COVID fibrosis or not. Okay. And if this is a continuing of a pre-existing condition or addition of a lung involvement of a continuing condition, that's going to be more important for us to distinguish, because I don't think even the surgical lung biopsy might not be able to distinguish this for us. So this is where the MDT would really have a better role. Even if you do your biopsies and if it's inconclusive, you really need to go back to your MD.
Okay, maybe we'll do a couple more questions. No, so we have quite a few, but we have a little bit of time left. I wanted to ask Dr. T. No, so obviously in patients with connective tissue disease, especially during the COVID era, if you give them immunosuppression, some of the patients will ask, will that not put me more at risk for COVID, etc.? Lalo if you initiate it in this timing or in this pandemic. How do you go about that? How do you discuss? How do you screen prior to initiation? And what's your comment on immunosuppressive treatment in CTDs in general or for ILD in the COVID pandemic era?
The most important will be to emphasize the need to wear mask to avoid. So sabi nga, may old Chinese saying, the best defense is distance. syempre, iwasan mo. But people, in context of COVID, airborne. So mask. Mask will be the most important. And then vaccinate. And many of our colleagues have already explained this in different societies. Even the Philippine Rheumatology Association emphasized that vaccination is an important and integral part of protecting ourselves from COVID. So with that, you can already assure the patient that it is relatively safe. And if they have COVID, the chance of them getting into severe or critical COVID is low. Third will be to, when you're about to start and they really ask questions, you can show the data. The DOH publishes its data every day, at least in the data drop still. So you can show how many patients are getting hospitalized via the number of cases. So first you have to make the patient feel safe. They may know it's safe, but if they do not feel it's safe, no buy-in. And then you start saying, continue discussing you are already immunocompromised, not just because of the treatment I'm going to give you, but because of your autoimmune condition with an immune system that is not properly functioning, you are already at risk. And what this drug, which I'm going to give you, is going to do is decrease that poor functioning immune system so that it can reorganize itself and then learn the difference between the enemy and the self. So it will really take time, no? And you don't just tell the patient, take this, all of you, no? Hindi pwede yun. And it's usually the first time that you explain it that it will take the longest. I hope it answers the question.
Yes, yes. And again, thank you very much, Dr. Albay and Dr. T. Really insightful and wonderful cutting-edge lectures. Full disclosure, I screenshot quite a few because I learned so much. Thank you for answering the questions. I'm sure our audience learned a lot from you today. And thank you again to our audience for all your interesting questions. Just quickly, this afternoon, we've learned quite a bit. No? Dr. Albay defined ILD or diffuse parenchymal lung disease for us as a heterogeneous group of non-neoplastic diffuse parenchymal lung diseases. He discussed the different diagnostic approaches, emphasizing history and PE, looking for things like age, sex, smoking, medications, and specific findings on PE. He clarified for us the function of the use of PFTs, BAL, surgical lung biopsies, and HRCTs, and the importance of the multidisciplinary discussion between clinicians, radiologists, pathologists, and other specialists as now being the gold standard as an aid for diagnosis. He mentioned as well, of course, in the pandemic, the changes or nuances in the pandemic, and occasionally deferring some of the procedures in most patients. Dr. T did a brilliant job of discussing incidents, genetic mutations, and other environmental factors for connective tissue-driven particular ILDs, immunologic factors, including toll-like receptors, B-cell infiltration, T-cell fibrogenic mediators. I really enjoyed, as you all know, the basic science of this lecture, the specific innate differences in prevalence and nuances in treatment for the different types of connective tissue diseases such as systemic sclerosis, RA, lupus, polymyositis, and Sjogren's, and the role of profibrotic mediators, in particular in CTD-associated ILDs, and some tips on treatment and importances with regards to treatment, particularly in the era of COVID and today. And so again, we'd like to also thank the Information Management Service Network team of the UP Manila and our sponsor, Boehringer Ingelheim. We'd like to thank you all for joining us. We hope to see you all again on the 9th of June, 2022 for another informative and timely lecture. And again, I'd like to plug that we have a new book, which is wonderful. It's an atlas of rheumatic diseases in the Philippines. In the chat, there's a Google form where you can order. It's a great way to teach and also to learn about the appearance of certain diseases. It will really fast break your knowledge in this field. And again, we kudos to all the authors and particularly Dr. Penserga for this wonderful achievement. Thank you again. Have a great afternoon and see you on June 9th for another informative and timely lecture regarding osteoarthritis. See you there and have a good day.